everyone. Welcome back to another episode of Research Works podcast. We're here at EACD Galway, Ireland 2026. I hope you've been enjoying all of the episodes so far. I'm sure you've been hitting download on the entire conference series. And as you know, we've been talking to a lot of the presenters, researchers from all around the globe about really important topics. And everything's been based around the F words as well. And we've been loving the conversations we've been having in terms of what interventions actually mean in accordance to F words as well. And today I have three guests with me to talk about a really important topic. I'll go through the title first. The title is Beyond Tone Reduction, Functional Effects and Muscular Adaptations After Botulinum Toxin in Children with Cerebral Palsy. There's so much to talk about here, setting the record straight as well. And so to join us today, we have Kaat Desloovre. I didn't do it well again, didn't I? But
no, that was perfect. Yeah,
perfect. Thank you. Thank you very much. And we've got Eva Ponting. Yep, she's nodding as well. Not too bad. And Anja van Campenhout.
Okay.
I think for the record, can you please say your full name? I feel like I butcher it every time.
Anja van Campenhout.
Wow, I did it so terribly wrong. Ed's laughing at me already. Let's not look at him. And Eva, I didn't say your surname properly.
Pontin, perfect.
Oh, I did do it quite well.
Yeah,
fantastic, fantastic. I think this combination, we were just talking before we started recording, about your background, your clinical background is really worth talking about to lay the scene here about why you are the people we need to be talking about botulinum toxin, because certainly online I've been seeing a lot of conversations about botulinum toxin, and unfortunately I think sometimes people like speaking in absolutes. It's botulinum toxin, bad, don't do it, not good for muscle. Let's actually go through the data. So Kaat, we've spoken before in the podcast. It'd be lovely to tell everyone your role in all of this and why we're here talking about botulinum toxin.
Well, first we started to evaluate the effect of botulinum toxin from the very beginning. So it has already been evaluated, applied, or in our center very frequently already for several years.
Yes.
And all the time we try to evaluate it. But the I think quite unique part of it is that we try to evaluate it in different aspects.
Yes.
Not only at the function, which is of course very important, the gait, but also at the level of spasticity that is reduced.
Yes.
Try to measure it. And also then the muscle structure.
Yes.
Because there were some concerns that the muscle structure would reduce. And then also the muscle composition, so the intrinsic quality of the muscle. Yeah. So all these things are put together to get a full picture of it, and that gives us confidence that
absolutely. And you're a very well established a group where anything to do with botulinum toxin, I see your name on as well. And are you a part of the same research team, same centre as Kaat as well? What's your role in all of this work?
I'm the one of the team that treats the children. So I'm the one that will give botulinum toxin, and of course has the same questions: when does it damage the muscle, and when does it do that? And so part of the work is taking biopsies before and after botulinum toxin. So that's also part of my contribution to the research that we are doing, and then looking at the clinical outputs. What does it change for the children? What comes with their function? Do they improve?
Wonderful.
And putting all these things together.
Wonderful. Really, really good. And again, you can see how that complements so beautifully. Eva, what's your background and what is it that you bring to this team?
Yeah, so I'm from Sweden, from Stockholm, Karolinska, and we've also used botulinum toxin just as long, like for 30 years about. And we also followed up with muscle biopsies. I'm an orthopedic surgeon, so I do both upper and lower limb, both surgically, and I also give botulinum toxin, and we've taken muscle biopsies before and after injections also. Yeah. And we are going to present here the results from the upper limb. But we also, in the lower limb, we're also doing biopsies and looking with MRI and DTI on that. So there's a lot of information coming.
Yeah, it sounds like it. There's a lot to cover, isn't there? And I think what's really clear from all of this is you're not just researchers, you're clinicians. You are doing both. So you're constantly seeing what's happening on the ground, which I think is really important. So let's start with this one. So botulinum toxin we know is widely used for spasticity for quite some time now. We know that. But there are some concerns around muscle health. what do we currently know about the impact of botulinum toxin on muscle itself? Who would like to take this one? Oh, everyone's looking to you.
Okay. So I think from our two groups, and I think we have the data to demonstrate because we compared pre and post, and we compared it also with healthy children of the same ages. And that's quite unique.
Yes.
And in the same muscles.
Yes.
Because there are a lot of studies out there that use different muscles, children of different ages. So it's very important to stick to the same muscle and the same ages. So what we know from our research is that when you inject, indeed, and this is, it will give some muscle atrophy and some muscle changes.
Sure.
But not as much as some of the studies before that's already shown. Out of theory, you know that when you inject a product that causes some chemodenervation, theoretically you can already deduct it will give some changes to the muscle.
Sure.
The only thing that we really wanted to know is how much and how long will it last.
Yeah.
And we've always been very carefully using the toxin. We don't do it like every 3 months, as in some centers, unfortunately, they do.
Yeah.
We've always had a long term in between it. So what we know from our data is that when you inject it and when you then measure afterwards, you have some minor muscle atrophy and some minor muscle changes, but it will recover.
Right.
Not
okay.
completely. So we have data after 6 months and after 1 year. And usually we don't re-inject before it's like 1 year. It's rare we re-inject before that. Never before 6 months, mostly after 1 year. So of course you can't compare these data with some of the things that other centers do where they would re-inject every 3 months. We don't have that data because we don't do it like that.
Right.
So we see recovery.
Okay.
So that's very important. But it also means that you have to wait long enough before you re-inject, because you have to wait for the recovery of the muscle.
Absolutely. So, and is that measured through MRI or is that through 3D muscle ultrasound? Are we looking at muscle volume?
Yeah, we have different outcome measures. So we have muscle volume measured both with MRI and mostly with 3D ultrasound.
Okay.
But we're also looking at the composition of the muscle.
Sure. That's where the biopsies come in.
That's where the biopsies come in. And also the MRIs, because that's an extension of the work. We're still continuing our research. We're not finished yet.
Yeah. How much data have you collected? Because this is from real clinical practice that you're collecting. What sort of, how much and for over what period of time have you been collecting this data?
Well, you need to, if you need to look at the whole package. So I would say it's more than 120 children who had a follow-up.
Wow.
But if we do the long-term follow-up immediately after botulinum toxin, that's a smaller group. So we look at the entire group, that's more than almost 400 measurements in total. And then for each child who gets botulinum toxin, we can also compare to children who were not treated. So you have also the comparison to an untreated group.
I see.
And what we especially then see, as Anja mentioned, so you have an initial atrophy and there is a recovery. But what changed already the clinical the way we treat them is that nowadays that we know that at 6 months there is still a recovery ongoing, that the parents and the physical therapists are advised to train them intensively in the period where the recovery should take place. Right. So you shouldn't do it initially because the first 3 months the muscle is not working that much due to the botulinum toxin.
Yes.
But then afterwards, you should, once the neuromuscular junction has recovered, you should intensively train it. And we are now trying to collect data to show, hopefully, that this might help. That's
interesting because I think in terms of my experience, often, you would have you'd wait and you'd start doing, say, therapy from 4 to 6 weeks when botulinum toxin was at its maximum, and you'd work from there. Then at 6 months, they'd have their next injection, and that routine would continue. So we're saying hold off on the next level of injection at the 6 months, not just because it's 6 months, but wait and start really training at that 6-month mark as well when there is a bit more of that recovery.
Yeah, it's a different type of training. I mean, like when the botulinum toxin works, when you have the spasticity reduction, then you would train the antagonists. Yes. You would do stretching on the injected muscle, try to improve your gait and your function. But when the botulinum toxin function wears out like after 3 months or so. That's the time when you also start doing some reinforcement of the injected muscle so you can recover.
Yeah.
So it's a different, I can imagine for some physiotherapists it's a bit counterintuitive to do it like that, but that's what we're now studying and seeing whether we can improve the quality of the muscle and see whether we can maintain function improvement as we already had before we did this training.
That's really interesting. Is there much of a difference between botulinum toxin that's used for spasticity versus dystonia, focal dystonia? Is that something that we look at, or is that quite a separate thing in itself?
Yeah. So regarding the upper limb dystonia I've looked at CP with not the dystonic type with the muscle biopsies, but I treat children with dystonia. I haven't taken muscle biopsies from them because it's a different way of using botulinum toxin to change the pattern of movement for some time. So that's something we really need to do. So that's a project that would be really great. So what we've seen when taking muscle biopsies from the biceps, we have given botulinum toxin also in the teenagers, which I think you don't have.
We have more younger children.
Yeah, exactly. So we've seen that in the younger group of children getting botulinum toxin, you get both a regeneration and a degeneration, but it's more the muscle gets back to what it was, gets more normal after a while. And you can see that it would be easier to train that muscle compared to the teenagers, where there's more deterioration of the muscle in teenagers. I would suggest to do more injections in the young population than in teenagers. That's what I would suggest.
I see. Is that
based on muscle biopsy?
Right.
Biopsies, yeah.
And why do you think that is?
It's easier for a very young child to regenerate because they grow so much.
Sure.
So it's their genetic framework is for growing. Therefore the botulinum toxin is not so detrimental to the tissue.
Interesting. I think that's really good to know because I think over the ages there's obviously then a difference. What about in the lower limb? Does that change over time? Because you said mostly is the younger children that you're looking at.
Well, we do, our data go from, let's say, 2 years of age until 12 years of age most of the time. We don't have a lot of data related to botulinum toxin in the older ages because it's not that often applied.
Okay.
So we now look into older patients, but not in the view of botulinum toxin. We want to know how the muscles develop.
Yes.
And what is also important in this whole story is that you try to put this all together in a wide picture because botulinum toxin is just one treatment.
That's right. Yeah.
And with all these longitudinal data that we have. Our PhD students could highlight that. So you have the muscle growth, it's decreased, it starts already at a young age.
Yes.
And we've been looking for all the potential influencing factors.
Yes.
And botulinum toxin was really a focus because of the concern.
That's right.
But most recently, we also looked at the impact of using ankle-foot orthosis.
Yes.
And how often these children use their ankle-foot orthosis. And by developing a multiple regression model, our PhD student highlighted that actually the impact of using ankle-foot orthosis or not is much more important than the impact of having a history of botulinum toxin injection.
Is it really?
Yeah. And this is just really new.
Totally agree. Yeah.
So it's more than just this. You really need to put it in a right picture and take at all the treatments and then also at the interactions of different treatments because botulinum toxin is often combined with other treatments.
Yeah.
So that's quite important to get a view picture. We need to be careful. We need to stay careful, but also don't make a conclusion on just one set of outcomes.
Yeah, absolutely. And I think that's what I've been seeing and hearing a little bit about is that, you know, if it's not good for the muscle and it's not good for muscle health, you shouldn't be doing it. How would you help to counsel a therapist or a parent that sees something like that and still presenting these treatment options for them? How do you do that?
Well, I think especially younger children, where you don't exactly know what their function is going to be when they're a bit older, botulinum toxin is still quite reversible, safe treatment. And we will continue to use it in the safest way as possible, meaning large intervals, training, to see how the child will cooperate with lower spasticity. And what's his strengths underneath and his proprioception, things like that. So as Kaat mentioned, there's a lot of treatments going on, but also within spasticity treatment, there's a lot of treatments. So often from using botulinum toxin and seeing how the child responds, we might decide to go for a more definitive treatment of spasticity, like a selective dorsal rhizotomy or something else.
Yes.
So this will guide us. So it's not once they've had botulinum toxin, you will need to continue over and over doing it again. It's to learn how the child will cope with lower spasticity, and to see what his future might be.
Sure. And how does orthopedic surgery fit into that? Because often, it's botulinum toxin to a certain point, and then they have muscle lengthening and.
Well, we still try to avoid muscle lengthening as much as possible because, there's a lot of literature now out there, a lot of concern. What does botulinum toxin do? But what does surgery do to a muscle? I mean, there's more atrophy there than after 10 vials of botulinum toxin. So we try to avoid this in the way possible by reducing spasticity, maybe in a permanent way. And I think orthopedic surgery is mostly important to correct lever-arms. So if you have a high femoral anteversion, then we will try to, of course, correct this. And of course, there are kids that need muscle lengthenings, especially the hemiplegic children, where it's often difficult to control muscle length. But try to do this just once and not continuously over and over again by using orthosis if necessary, and other means to control muscle length.
There's a lot of tools at our disposal here, really, aren't they?
So regarding the upper limb, it's very important to keep out the length. So if you would inject the biceps, if you stimulate the child to really extend the arm, you would stimulate length of the biceps. And if you combine that with, and also for the finger flex and the wrist flexors to have night orthotics, that would not injure the child during the day, and you will keep length of the muscle. So if you do that early with an orthotics, night orthotics for the arm is important. And of course, AFOs. I agree totally with you. With orthotics, you keep the length of the muscle without surgical intervention because we use knives. I mean, they're dangerous, so it's that does injure muscle more than botulinum.
We want them to use their muscles.
Exactly.
Yeah. What would you say is the biggest difference between your thought process and your care around upper limb botulinum toxin and lower limb botulinum toxin? What would you say would be the most distinguishing factor?
For me, I would give botulinum toxin to make it easier to use orthotics. For example, if it's very difficult to get their heels down to the ground, and for the upper limb, it would be for functional. I want the child to really reach out or to open up the thumb.
More functional based.
Yeah.
Everyone agrees?
Yes, I do.
No counter.
Well, I think for low limb, we also hope that it will improve the function of gait.
Yes,
Right.
that's right.
That's also, we do see that. But there you need to also evaluate it in a proper way to highlight that. Yeah.
Absolutely, and everything has to come down to measurement. What about serial casting and botulinum toxin? Is that still used? Do you still use that a lot in your clinics?
We do.
Can we see what that
but,
does from a muscle perspective?
We have some studies on it as well, and to even compare botulinum toxin with and without the casting. It's difficult to gain length with the casts. If you look at what we can see with ultrasound, I think what you gain more is the tolerance to the stretch and the tolerance to tolerate the braces. But you can gain time by using it to get them not into surgery at a very young age.
It's not so much a decision whether you would use casting or botulinum toxin. It's more like we can combine it.
That's right. Yeah.
We do the same. So,
same.
So we try to postpone surgery by doing that. So if hopefully not needing lengthening surgery, but either or postponing.
I mean, this is obviously a very big topic that we're talking about in a very short period of time, but still, like, so much food for thought here. What will be your final message? We'll go to each of you. Kaat, what will be your final message with regards to the use of botulinum toxin and how that integrates with F words or recommendations? What would that be for you?
Well, I think it would be the same as how I started.
Yeah.
Look at it in the full picture.
Beautiful.
Never look at just one outcome.
Yeah, that's right.
It's important.
What about for you, Ed?
Yes. So botulinum toxin is to make it easier for the child to walk and to use their hands. So it's a functional approach.
Yep.
To make it easier to use orthotics, to walk, to reach, to grip.
Beautiful. Beautiful, beautiful. Anja?
I would say that function, of course, is very important, but you have to look at function now, but also at function in the future.
Yeah.
So sometimes you have to do things now that are important for the kid's future.
Yeah.
And that can sometimes include using botulinum toxin.
Yes. And that's why this study is so important, to understand all of this, to be able to actually provide that information for the future as well. Thank you so much for speaking with us on the podcast today. I really enjoyed the conversation, and again, it's just always good to go back to the people who are actually doing the research in the area, who are actually seeing the muscles under the microscope, to be able to understand the role of botulinum toxin and to just to make sure we're going always back to the science and not following maybe the hype that we might see online sometimes. And I think that's really important. So thank you for laying all of that out. It was very educational to all of our listeners. I hope you really enjoyed that. Again, another great conversation and to add to your toolbox of information that you get from this conference. But we'll talk to you all again really soon. Bye.
Bye.